points. Now today we will be discussing about the anti-tubercular drug. Normally when a patient comes to you has been diagnosed as tuberculosis, now our further plan will be for treatment. As we know, it is everybody knows about that drug treatment, the major 5 drugs as a first line drug, and then there are the second and third line as well. But the first line drug is enough for drug susceptibility test. Drug susceptible TB and can be treated with 6 months. If it is a sensitive TB, and this drug will be enough for it. Before going into the doses, actually today we will be discussing about the practical approaches, practical line. When a patient came to you, you have diagnosed as TB, it may be clinically you are giving an empirical therapy, or you have a confirmatory microbiological confirmation. Since you can have in your life there will be a lot of time, then you have to use this tubercular drug empirically many times in your life of career as a doctor. So you should know the practical approach of drug, what will be the dose, how much maximum we can go, what will be the side effect that we will encounter, and other practical things that I will discuss here. Suppose a patient came, okay, he or she has the constitutional symptom like weight loss, fever, evening rise fever, then weight loss is there, sputum production with maybe there is a cough with even hepatitis he has presented. X-ray finding suggests that there is a evidence of tuberculosis finding. Even you have done the sent for the microbiology for ARP and gene export, they both are positive. Gene export shows that the reformation is sensitive, it is not the resistant one. So it's a clear cut TB. Now we are going to manage. For managing, what you do, you'll choose that drug. According to the weight, we usually give the drug. Okay. So our drug of choices will be isoniazid, rifampicin, pyrazinamide, ethambuta, streptomycin, and there will be the vitamin B6 supplementation for prevention of neuropathy induced by the INH. So we have initially the usual treatment was of 9 months of the primary pulmonary TB, but when paracetamol was added, it was reduced to 6 months. So when you are going to choose 6-month regimen, and then in that we will be using 4 drugs for 2 months. The 4 drugs usually we select is isoniazid, rifampicin, pyrazinamide, and ethambuta. Streptomycin is usually not selected. Okay, it has a propensity, it has side effects to cause renal toxicity, nephrotoxicity is there. Even so we usually don't prefer. All aminoglycoside acid has kidney toxicity, renal toxicity, and ototoxicity. If you are going to use that, then we have to monitor that as well. Since we have other 4 drugs, then we usually don't prefer it. Okay, and with supplementation of this vitamin B6 marathon. Okay, now the thing is that what will be the dose of isoniazid? Isoniazid usually we give 5 mg per kg body weight, and if it is a 60, 70 kg man, 70, even 80, then you prefer 300 only. The maximum dose you can go to 450 mg. But remember, we have I think treated 300 to 400 patients, and among them 3 patients we have used, due to the body weight, we have gone to the higher doses, that is 450 mg. And what we observed that among 3 patients, 2 were developed INS psychosis, that is isoniazid induced psychosis, and it was severe. He was psychotic just after starting the drug. So we stopped it, and in 2 to 3 days after stopping, it is reversible and it gets resolved. So it's always better not to go above 300. Okay. In case of rifampicin, the usual dose is, you know, that 10 mg per kg body weight. We can, if a 60 kg man, we will go for with 600, even 70 kg 600, 80 kg 600. You can reach up to 900, but there will be the side effect. So the maximum dose you prefer for, if it is a lower weight, then it can be, suppose it is a 40 kg or 45 kg, then you can use 450. But if it is a 50 kg, you will use 600. If it is 60, 70, 80, use 600. If it is 45 or 40, then you can use 450 only. Okay. Then comes to the pyrazinamide. Pyrazinamide is usual dose is 25 to 35 milligram per kg body weight, and that we usually give as a for better practical approach. You can use the 30 mg. That will be better. If it is a 60 kg man, then 60 kg man or woman, then you use 3, 6, 18. That is 1800 will be enough. You can use 900 BD or even 1 gram BD. The maximum dose you can go up to 2 gram. So if it is come 70 kg man, 70 into 3, 7 3s are 21. It's come 2100. You are not going to give 2100. You will maximum reach to the 2 gram. That is 2000 only. So you give 1 gram BD. If it is lower, you can give the lower dose according to the weight. Okay. Now the point of ethambutal. Ethambutal is 15 to 25 milligram per kg body weight. You average use the 20 milligram per kg body weight, and usually if it is a 60 or 70 kg man, 60 kg you will give 6 to the 1200 mg OD you can give. Okay, you usually give at HS in the evening. The maximum you can reach is 1600 mg, but you have to know about the side effects. I'll come to it. Streptomycin dose is 50 mg per kg body weight. If you are not able to use this ethambutal pyrazinamide due to any cause, then you can go with streptomycin. Okay, that will be our drug of choice. Okay. Now, what are the side effects? And the side effect of the isoniazid will be 2. If you are a Asian, then we are a slow acetylator. There are 2 types of acetylation. That is the liver metabolism. There is phase 1 and phase 2. So when it comes to the Japanese, they are fast acetylator in phase 2 reaction. But when we come to the South Asian, they are slow acetylator. Due to fast acetylator, rapid metabolism of drug, the Japanese has a propensity. Japanese will develop hepatotoxicity from INH, but from isoniazid. But from when it comes to us, then it will be that we will develop peripheral neuropathy. That is important. Okay, that will be one point. Second will be that reformation. Reformation is must, or there are many side effects. Among this, hepatotoxicity is the major one that you have to remember. Okay, another will be gastric problem. There will be gastritis. There are a lot of other cholestatic hepatitis will be there. A lot of issues there. But main thing is what we will encounter is reformation with hepatitis. Okay. Then comes to the pyrazinamide. Pyrazinamide will the side effect measure will be hyperuricemic count. So you have to check the creatinine. The hyperuricemic count. So you have to check the uric acid level. Okay. Then comes to the ethambutal, ethan for eye, that is leads to the optic neuritis. You have to have a checkup of your eye if you are giving ethambutal to a patient. Okay, and then streptomycin, it has a kidney injury, and also it may cause autotoxicity. To reduce this peripheral neuropathy, the vitamin B6. This is vitamin B6. This is vitamin B6 that can be used. Okay, and vitamin B6. This is pyridoxine. The dose is usually this is a vitamin supplementation. You can go from 10 to 50 mg. Some literature says you can, if it has no any risk factor, then you can use only 20 mg OD. That is 40 mg tablet you can form, half tablet OD. You can give 40 mg OD, but there are certain conditions where you have to use the higher doses. Like it may be pregnancy, then patient is a diabetes, if it is alcoholic, if it is a malnutrition, if there is any renal disease, if patient have HIV concomitant, that is comorbidity, if with TB and HIV, then you have to use the higher dose. That you have to understand. Even if you are going to treat MDR TB or pericardial TB, TBM, then also you think of higher dose. But normally this pregnancy, diabetes, alcoholic, malnutrition, HIV, these usually require higher dose of this vitamin B6 supplementation, and you have to use that. Okay, so it will be either 20 mg you are using, either 40 mg, or even if you are thinking it's required the higher doses, then 80 mg per day can be used. 2 tablets can be used. Okay, so it will be not a big problem of this. Now you have came to know about the maximum dose also, where we can use. If you go with the maximum dose of this 450, then you will develop INS psychosis. If you are going to give patient higher doses, then there will be liver injury. Okay, if you are going to use more than paracetamol at higher doses, then there will be hyperuricemic. Or if you are going to use ethambuta more higher doses, then there will be a chance of optic neuritis. Even at the lower doses also, you have to screen the side effect as well. Okay, now coming to the major point is what we encounter if we are going to manage. Then among 10% you will find, we have found in about 50% of the patient will develop this drug induced hepatitis. That is, if you are going to manage there will be development of anti-tubercular treatment, that is ATT induced hepatitis. When you will suspect, when you will label, when you will know that it is due to a drug induced hepatitis. If a patient has started the anti-tubercular drug, and if these things occur, that total bilirubin it was normal baseline, but it has increased up to 3 millimole per liter, then you have to think that is okay, it is ATT induced hepatitis. If total bilirubin has increased, or if liver enzyme has increased, liver enzyme that SGPT or SGOT both have increased. If they are increased, then there is actually in literature you will find that liver enzyme greater than 5 times increases term as the ATT induced hepatitis. But if patient has a symptom and the liver enzymes are raised greater than the 3 times its upper limit, then we also consider it as the ATT induced hepatitis. So ATT induced hepatitis can be called if a patient has normal bilirubin but now raised to the 3 millimole or even greater than that. Okay, if the liver enzymes are increased, if liver enzymes are increased and patient has the symptoms. What symptoms? Mainly a hepatitis patient if has developed, then there will be few symptoms like we can say that there will be a nausea, vomiting, anorexia. These will be the major complaint of a liver induced. The liver injury and patient will feel anorexic, nauseatic, vomiting. Okay, and obviously with symptoms there will be also a bilirubin raised as well. And if it is no symptoms but liver enzymes seems to be increased, that it should be 5 times than the upper limit, then only we can say that it is ATT induced hepatitis. If ATT induced hepatitis has been diagnosed, you will stop this 4 drug, that is isoniazid, rifampicin, paracetamol and ethambuta. Stop it, then go for the stop this and go for start. You can you continue this ethambuta. Without ethambuta, there is no side effect of liver toxicity, liver sparing drugs. So liver sparing drugs should be started, and liver sparing drug is ethambuta, levofloxacin, and amikacin. Okay, so we have now diagnosed ATT-induced hepatitis. So since ATT-induced hepatitis has diagnosed, now you have stopped the drug and started ethambutal, levoflox and amikacin. One thing you have to say to the patient that levofloxacin should be used 2 hours gap with milk and milk product. So if person is fond of milk or milk product they are taking, everybody use it. So there should be a gap of 2 hours. So levofloxacin if you are taking now, then only after 2 hours you take the milk and milk product. Or if you have taken the milk and milk product now, then take after 2 hours. So there should be a gap of 2 hours to use this levofloxacin. Okay. So when you have now started with ethambutal, levoflox and amikacin. Since this three have been started, now the liver enzymes will come down to normal in 1 hour, in 5 days, or 3 to 5 or 7 days. If it comes to the normal, then what you do? Now you will check. Now you don't know which one is the responsible for your drug-induced hepatitis, which one ATT-induced hepatitis. So you don't know which one is different. It is reformation or isoniazide or pyrazinamide. Pyrazinamide. So what you will do? You will have, when there is saying that, if usually what we do, practically we let the bilirubin to come down normal, continue this ethambuta, levoflox and amic acid. Amic acid is usually given in 750 mg is given in 100 ml of NS over 30 minutes. Okay, that is practical information. Then what we will do, we will start, if according to literature it said, then if bilirubin, total bilirubin come down to less than 2 millimole, or the liver enzyme is less than 2 times normal, means if it is elevated but less than twice of the upper limit is there, then you can introduce this drug one by one. But we usually, in practically what we do is we let this bilirubin and liver enzyme comes to the upper limit of normal range. Then what we do, we introduce reformation, isoniazide and pyrazinamide one by one. Okay, so first we induced reformation. We started the reformation, usual dose. Now ethambuta, levoflox, amic acid is going on. Reformation is, you have started. Since reformation you have started, now what will happen? If there is no increase in the bilirubin or liver enzyme, then we usually think that reformation is not the culprit of this hepatitis. So you will now continue reformation as well. Now after the introduction of reformation, now we will introduce INH. If INH is also introduced, and if there is a development, if there is increase in bilirubin or liver enzyme, then we will stop it. If it is not increased and it has been well tolerated, then we use INH as well. Introduce INH as well. Okay, then you can stop this amic acid. And reformation INH, ethambuta and levoflox will continue. But you have to understand that this pyrazinamide, if you have checked this, it is tolerated. If you have checked this, it is tolerated. Then it is not necessary to check pyrazinamide, because we already know that if this two has been well tolerated as not responsible for hepatitis, then we presume that this is the drug that has caused our hepatitis, and we usually not use this. Then our drug is continued. If you are, we can use now reformation, INH and ethambuta. Even levoflox can be stopped, or amic acid can be stopped. Okay, it's depend. Then the duration, since I have told you that pyrazinamide was added, then its 9-month duration was come down to 6 months. So if you are not using pyrazinamide, then if you are going to continue 3 or 4 drugs, then it will be 9-month regimen. That you have to understand. One thing more is important is that how you are going to understand that it is a reformation responsible, or INH responsible, or pyrazinamide responsible. We can do one. We can check for the bilirubin and liver enzyme. If only bilirubin, total bilirubin is raised, okay, and alkaline phosphatase, then this type of scenario usually occur due to reformation. It is known as the cholestatic hepatitis like feature. So bilirubin is raised, alkaline phosphatase is raised, but SGOT and SGPT are normal. They are normal. They are not raised. So SGPT, SGOT, you are saying this is not raised, but you are saying that person has total bilirubin raised. If you go down and check the report, there will be alkaline phosphatase is also raised. In that situation, your culprit of drug to cause hepatitis is reformation. So if you are finding this situation and you are diagnosing as ATT-induced hepatitis, then this is the drug, reformation is the drug that is responsible for it, and you have to discontinue this, and even you can continue this INH, pyrazinamide with ethambutal, and you can add levoflox or amic acid. Levoflox or amic acid. It's dependent on you. Okay, or you can stop this 3 drugs. Start with ethambutal, levoflox and amic acid, and then later don't add this when the liver enzyme count normal, add ionets and paracetamol. Okay, you add ionets and paracetamol. If these are well tolerated, then stop this. If they are also not going to be tolerated, then you have to stop that as well. But usually, if bilirubin, total bilirubin is only raised, alkaline phosphatase rate, but SGPT, SGPT are normal, then reformation are the culprit for drug-induced hepatitis. If we are going to talk about, this is one scenario. Another scenario will be what? Another scenario will be total bilirubin normal, then SGOT, SGPT, liver enzyme. These are only raised. Mainly we consider for PT. Okay. So this liver enzyme is raised, but bilirubin is normal. Even alkaline phosphatase is normal. Then in that scenario, your ionets and paracetamol, either this or both are responsible for your hepatocellular damage, hepatocellular cell damage. That is important. If liver enzyme are elevated, ionets or paracetamol is responsible. Bilirubin will be normal, alkaline phosphatase will be normal. If bilirubin is elevated, liver enzymes are normal, then think for reformation. This is usually a presenting mention in the literature that it will help you to find out the cause. And once you have find out the cause, then you will stop that drug and use other first line drug. Always remember, when you are going to treat TB, if the first line drug is sensitive, then try to complete the regimen with the first line drug. Okay, then that is very important. There are other things as well. When you are going to one drug, more can be added, that is cycloserine. So if rifampicin can be added, suppose the patient ionets and pyrazidamide is not tolerated, you develop hepatitis. So rifampicin you have added. Then there is ethambuta, levoflox. Then another is cycloserine can be added. Cycloserine or amikacin. Usually given amikacin. One thing you remember that if you are going to treat TBM, tubercular meningitis, okay, in that case, suppose ATT-induced hepatitis develop, you have started ethambuta, levoflox and amikacin, then liver enzyme from normal, you goes with the reformation has been started, it is well tolerated, you goes to the ionets and pyrazidamide, they are not able to tolerate, again develop hepatitis, so you stopped it. Now you have reformation that can be added to the regimen. This time reformation you have added, then ethambuta you have added, levofloxacin you added, now amikacin you will give it. You have to consider one more thing, that if you are going to treat TBM, okay, then cycloserine and amikacin, these two are the drugs which you can use in your first line regimen. The cycloserine, if develop neuropathy, then in TBM patient it will be not be monitored. So if you have a tubercular meningitis patient, you are treating it, go for amikacin. Its side effect is nephrotoxicity. That can be measured. But if side effect of cycloserine, that is neuropathy develop, you cannot be measured in TBM patient. So in TBM you will reformation, ethambuta, levoflox and amikacin. If it is pulmonary TB and you are saying that patient is old age or your kidney condition does not allow you, then you can use cycloserine. Okay. One more thing that I will add to this is that when we are going to treat the MDR TB or XDR TB, or you are not able to use the first line drug due to any reason, maybe due to you have hepatitis or other condition, then there are two drugs, that is para-amino salicylic acid, PASA, and another is ethionamide. These two drugs will cause hypothyroidism. And since these are responsible for hypothyroidism, you have to check the thyroid level as well, and if it is low, you have to supplement with thyroxine. That's all. Thank you.